Thank you.
The next speaker is Julia Mayerle from Munich, and her talk is Screening, Surveillance, and Targeted Therapy in Pancreatic Cancer. Very important talk.
I don't know whether it's a very important topic, but at least we have 2 talks in this meeting on the same topic. And I would have loved to listen to Marco Bruno's talk tomorrow and have a discussion together, but I think now you have to remember my talk and then ask him the nasty question, because I will always point to his talk and say, he's gonna answer.
You can join via Zoom tomorrow.
Yeah, I will. Okay, so the topic, and let me first thank the organizers, and especially Peter and his team, for inviting me again to Budapest. It's always a pleasure being here. So thanks a million. And it's also nice to see the Hungarian Pancreatic Societies thrive, something the Germans haven't really managed to, and we envy the Hungarians and the Dutch. Okay, so pancreatic cancer screening, surveillance, and targeted therapy. We all know that pancreatic cancer has the worst prognosis of all GI cancers, and I really like this picture because it tells us that it will take us until 2190, so none of us will really experience that, if to cure pancreatic cancer, if we keep the current pace. So it's devastating, a long way, but maybe it also motivates a lot of us to work on this field. So, and if we look at these figures, we have to think, how can we actually change that? And yes, we can do doublet chemotherapy, triplet chemotherapy, quadruplet chemotherapy. But we could also think about screening or surveillance, and hereby maybe find the cancer earlier, and hereby increase survival. However, one of the biggest problems here is that we are really dealing with a low incidence disease. And then whenever you think about screening, you can do that perfectly well in a high incidence disease, but if it's a low incidence disease, then you're looking for the needle in the haystack. So this is when you really have to think about a strategy. And one strategy is that you're creating seeds. So and then if you look at the general population and you think about your first seeds, then you should define and coin a risk cohort. And you also have to define how high the risk needs to be, balancing the quality of your second seed. And this is either a phenotypic marker or a serologic marker or some non-invasive imaging as a second seed. And those have to always risk to be or balance risk and prevalence or incidence. In pancreatic cancer, incidence and prevalence is more or less the same, which is devastating, but unfortunately true. So when you think about what could be risk cohorts in pancreatic cancer or for pancreatic cancer, then you again have to look into the question, do I have a very highly increased risk of pancreatic cancer, like in hereditary pancreatitis, a disease which was more or less developed by Dave Whitcomb, or identified, where you have, well, not developed, sorry, identified. But you brought us definitely to our mind, let's be frank. So, and we know from several studies, the last one by Vinciane, that the cumulative lifetime risk of pancreatic cancer in those patients with a trypsinogen mutation is roughly about 40%. So that's very high, but we also know that the prevalence is probably only 1.3 per 100,000 population. So we have a very high relative risk, but a very low incidence. So then you see, then you have the intermediate group where you have a cumulative lifetime risk between, say, 0.34, like in familial pancreatic cancer, depending on the number of relatives you have, and maybe chronic pancreatitis. I think the number given here with 1.95% is pretty high because there are no very good longitudinal studies, but they are always case control studies. And I think it's overestimating the incidence, but say it must be somewhere around 0.5% in somebody who suffers as a cumulative lifetime risk for pancreatic cancer. So that's an intermediate risk, but you have a higher prevalence. And then you have low risks and intermediate prevalence, like in BRCA2 mutations or in sporadic PDAX. So in those patients, you could go for surveillance. And yes, we can discuss that it's very difficult to go for surveillance in hereditary pancreatitis, and I'm sure Marco will tell you this tomorrow and outline this to you very clearly. You could also concentrate on the intermediate risk, and then you would talk about screening, but not screening in the general population, but screening in an intermediate risk group. So the next question is then, what's my second C? And I'm presenting you some data which we have been working on in recent years. And well, it's also 10 years, to be frank, that I just recognized when we started that. So we thought one sieve could be a metabolome analysis. That is technically possible. Whether it's clinically relevant, the future will need to tell us. So what is the metabolome? We use the plasma metabolome. And if you think about how the different layers of how our body is composed, then you have the genome translating, which is translated to the proteome. And the proteome is then metabolized or influences, or the enzymes influence the metabolites. And then you get a whole portrait of what is ongoing in our body or body fluids. How are metabolites defined? It's very simple. They're below 1.5 kilodalton, and they're glycolipids, polysaccharides, short peptides, or small oligonucleotides. So you have a number of different sorts of small molecules, and they can be actually identified by mass spectrometry. And depending on the quality of your mass spectrometer, you find more or less of these metabolites. So initially, what we did was we analyzed 914 patients with chronic pancreatic cancer and controls. And we found 477 high priority metabolites from 10 different ontology classes. To me, the major surprise in this was that 64 of these best discriminating metabolites belong to the group of complex lipids, fatty acids, and related metabolites, a group of molecules I never paid any attention to. You see the metabolite names here and also the signature and panel, and you can see the diagnostic accuracy. So you can discriminate between pancreatic cancer and chronic pancreatitis with an accuracy of 90%. And if it's resectable, then it's even better, then it's 91%. So in principle, you would think, perfect, let's take that to the clinic. But then if you look, and this is just the data on the resectable patient to show you that it's really better than CA99. But then again, if you really want to take such an assay to the clinic, and if you look into FDA requirements, then you recognize that a simple gut paper doesn't give you, doesn't lead to reimbursement in the healthcare system, and also not to clinical distribution. So in the next step we said, well, first we have to validate that again in an independent cohort. And in the validation cohort, we again took quite a huge number of patients, and you see there 202 cancer patients, 144 CP patients, and non-pancreatic controls. So they are not healthy, but they are different controls we believed would be relevant to the disease, including liver cirrhosis and before small operations to correct for that. Most of the cases of PDAC were collected before an operation. And then we also thought, as we were just discussing, it would be good if we So in the first instance, we just validated it, and this is the blue and the red line, and you see it works perfectly all right. So we have a negative predictive value of 0.995. So why I'm giving you the negative predictive value? Because we are talking about looking for the needle in the haystack. So it's not that somebody comes to your practice and asks you, do I have pancreatic cancer? But you want to exclude that he is suffering from pancreatic cancer. Because the number of patients where you want to exclude it is much higher than the number of patients where you actually want to can diagnose it. So positive predictive value in this scenario is probably of less importance to your clinical management strategy. But then again, we thought if we would take 9 to 10 parameters and design an assay here, it will be relatively costly, and also it will be hard to implement in different healthcare scenarios. So this is why we made use of a machine learning approach, and we used the BaseML model, and we downscaled the number of metabolites without losing accuracy. And this is what you can see here. And then in a second step, then we ask ourselves, do we really need CA99? And this is even more important. The model works as well in the non-secretors of CA99 as in those which do secrete it. So that doesn't mean that you can leave out CA99 of the panel, but you don't lose your diagnostic accuracy in the patient where from their genetically background, they cannot produce CA99. So then again, in the next step, we were asking ourselves, can we prospectively validate it in a high-risk cohort? And then I was calculating, I did my sample size calculation. And if I would try to do that in chronic pancreatitis patient, I would need to recruit 29,000 patients. Same for diabetics. So if you have an intermediate risk to validate such a biomarker assay in clinical routine, 30,000 patients. Impossible, nobody will finance it. So the strategy we came up with is a so-called enrichment design. So we were recruiting 1,372 patients with the idea that they were admitted to hospital with an unclear focal mass. And many of you in the audience would say, if somebody comes with an unclear focal mass to your practice, then the likelihood of pancreatic cancer is 80%. The likelihood, if you look into the literature and also from what we found here, is rather something between 6 and 20%, which then downscaled our sample size calculation to 1,300 or 1,250 and gave us the possibility to prospectively validate a biomarker panel. And that is something which is suggested to do by FDA to actually reach clinical practice in a, say, timely manner. So we've finished recruiting this cohort. We are on our way to clear application. We hope that we would be ready for clinical use in 2024. And these are the very, very preliminary data because we haven't closed the database. So we are not entirely sure of all the clinical data to correlate it, but we have done the metabolome analysis for all. And you can see that there's a clear correlation or between cases as pancreatic cancer cases and controls. So the likelihood that we will be successful with the approach is getting higher by the minute. Another cohort where such an approach could be applied would be the patient with newly diagnosed diabetes. And I'm just showing you this slide for the reason that it also gives you a second aspect of what you have to think about. And this is if screening and surveillance would be cost effective in pancreatic cancer, if the sensitivity of a test exceeds 88% and the specificity is given with 85%, if the costs for a test would be below 400 euros, and that's calculated for the UK and Germany, so for a Western civilized country, it might be different in other countries. And if you would be willing to pay 13,500 euros per quality adjusted life year. So you see there are multiple factors coming into play if you think about developing a biomarker for the early diagnosis of pancreatic cancer. So that brings me to my the second part of my talk, and that is precision medicine in PETA. So with a focus on lipid metabolism, as I just told you, it was strikingly for me that lipid metabolism is totally disturbed in pancreatic cancer. So we know from 2015 onwards that by virtual microdissection, we can discriminate between classical and basal-like pancreatic subtypes. In 2018, we learned that we can do real-time characterization. And in 2021, we can do, and this is what you see on the right side, EOS-based organoid culturing, and we can do drug testing. And we have, in this situation, about 30% change in patient management, according to what we find after genetic analysis and analysis of drug vulnerabilities. When we look for sphingolipid metabolism in this situation, then we see that there are sphingolipid metabolism associated genes, and they show differential expression. And I'm showing you two genes, that is SAH1, which is acid ceramidase, and SMPD1, which is acid sphingomyelinase. So one is upregulated and one is downregulated in basal subtype. And you can also see that that is associated with survival. So why is this? Because ceramides are actually not a single moiety, but they're different chain lengths. And about half of the ceramides are actually generated by SMPD1. And they all have different actions. So one can be proliferative, one can be anti-proliferative. So there needs to be a balance taken. So high SMPD1 expression is associated with an increased survival. And if you do cell line experiments, and I don't want to go into detail here, or if you take transgenic animals, that what eventually you find out is that SMPD1 function as a tumor suppressor. Does that help us in clinical practice? Well, go back to the plasma metabolome. If you do look for subtypes in the plasma of pancreatic cancer patients, then you see that there are 3 different subtypes. It's no longer classical or basal or mesenchymal, but there are 3, subtype 1, subtype 2, and subtype 3. And it moves on. Go one back. Back. Okay. Keep it. Keep it like that. Okay. Yeah. Okay. So you see that there's the subtypes, and then if you do network analysis, you see that those are central players, and you can also develop metabolic programs for this. So the plasma meta-analysis of PDX shows significantly enriched metabolic programs. And the interesting thing here is, I'm not a big fan of subtypes, to be honest, but I'm a big fan of if I can actually monitor subtypes in a non-invasive compartment. And I can also monitor treatment effects if I just draw blood and don't need a tissue biopsy. And even more important, this does correlate somehow to survival. Whether it affects treatment, we have to show. So when it comes to targeted therapy as a third approach on treating pancreatic cancer, then I'd like to give you just 2 slides and very short, and describe a recent study which Ujjwal Mahayan, postdoc in my lab, published in Gastroenterology, And this is a tumor-specific delivery of 5-FU incorporated into an epidermal growth factor receptor 1 aptamer. Long word, but if you look in the center of the slide and you look at the EGFR receptor and the chain, then what we did is we exchanged all uracil residues in the aptamer against 5-FU. That allowed us that we had 11 5-FU molecules in a single aptamer, and that attaches to the 5-FU to the EGFR receptor, is endocytosed, so it's specifically targeted to the cancer cell, endocytosed, released, and then you have the efficacy of 5-FU, and you also overcome the classical resistance mechanism of 5-FU, which depends on the uptake mechanism and the pumps to actually intake it. Because you have an endocytosis mechanism, a different mechanism of uptake, you're even in 5-FU resistant cell lines still efficient. And this is what you see on top. Your efficacy is 2 log phases higher than if you use systemic 5-FU. So if you use these drugs in KPC animals, then you can clearly see that there's a halt in tumor growth, and that is measured on MRI. And if you look into organoids, human organoids, and you compare control, 5-FU, an EGFR aptamer, and our 5-FU EGFR aptamer in a relatively low dosage, then you see that the killing takes place much better in the 5-FU EGFR aptamers if you control it to 5-FU, even in the same concentration. Like you see the 30 nanomoles and the 300 nanomoles, that accounts for the 10 times higher concentration incorporated into the aptamer. So, and with this, I'd like to summarize. A first step to improve outcome of PDAC can be screening or surveillance. Screening will only be meaningful in a higher risk cohort with a PDAC incidence of at least 0.71%. The use of a metabolite signature could be promising, but we have to really show that. Sphingolipid-driven PDAC metabolome subtypes reflected in plasma might be helpful to monitor treatment response or to define vulnerabilities for specific regimens. SMPD1 acts as a tumor suppressor in pancreatic tumorigenesis, and 5-FU EGFR aptamers serve as proof of principle for cancer cell-specific drug delivery systems and could become a backbone of EGFR positive cancers in need of 5-FU therapy. And with this, I'd like to thank you and I'm happy to take your questions.
Thank you for the talk is open. Peter.
I congratulate to the presentation and also to the topic. In one of the slides, you mentioned that it would be economically, and well, it's something around 81% specificity and sensitivity. But which population you are referring? Because generally our problem, the low incidence, what you will do with the false positive cases, which will be a huge one.
So, the risk of the cohort should be an incidence of prevalence of roughly 1%. If it drops below 1%, it will be the number of false positives will be too high to really make it meaningful.
Yeah, but do you know about what would it mean? How many percentages of cancer could be found beforehand? Because most of the patients.
So if you think about the population of diabetics, where you would say that according to current data from Surashchari, and we wait for the study in the United States on a population or on a larger scale, there you would estimate that the number of cancers in this cohort is roughly 0.7 to 0.85%. So in those, if you would use a test which the sensitivity and specificity I outlined, then you would detect about 50%, you would detect the cancers and you would reduce the cancer burden by 50%.
I have a questions again in the Zoom.
Hi, Shmuel.
Hi.
Good to hear you. I can't see you, but I hear you.
Well, I can put my Zoom, but let me see if I can put my camera on. Okay, this metabolites issue is really interesting. And the question is, do you know which cells is generated, especially because it is so much lipids, which cells in the tumor, or is it the pancreas itself that is changing? Because then you can go and with the biopsies can get a little bit better confirmations about the tumor, the state of the tumor and so on.
That's a very good question. We are currently working on exactly this question. What I can say so far is that it seems to be a reaction of the host to the tumor, if you can say so, because the tumor burden in itself does not increase the abundance of complex lipids. So it's not a direct effect of the tumor cells, nor are the tumor cells leaking the sphingolipids to the plasma. So, but that is something which we really are trying to investigate in more detail with genetically modified animals and to deplete those. But it's a very good question, but in resectable stages where you have a very low tumor load, the diagnostic accuracy is higher and not lower.
Well, because remember, the duct is really good in eating and generating lipids. And one would think, because that's why I was asking if it is the tumor, because the duct itself is where these things start.
My current knowledge is that it's much more complex, and it's shuttling between the plasma membrane, and it has a lot to do with membrane fluidity and cholesterol transport and ApoE. So I'm currently trying to understand how it actually works, and I will tell you in a couple of years, but a very precise answer at present I can't give you.
Thanks.
All right, Julian, really nice talk. I enjoy it, especially the lipid metabolism part. I like the other one as well, but I'm particularly interested in this one. So you seem to be, your data showing that the sphingolipids and the related genes really make a difference. And it's funny that I'm not sure if you have looked at the cholesterol, because cholesterol and sphingolipid are the two major components for lipid routes at the membrane trafficking. And we've done a lot of studies on cholesterol side and also lipid route trafficking. So have you seen any of those?
On
cholesterol.
Cholesterol, yeah, okay, sorry.
Sorry.
Well, I have to look that up because we are currently following up cholesterol metabolism exactly for the reason to see the link, because we also believe that that has a huge effect on membrane fluidity. And so what we know is that we have looked for the chain lengths of ceramides and sphingomyelins in cancer versus controls. And we've used pancreatic cancer, prostate cancer, lung cancer, and breast cancer. And we see that there's an inverse correlation with chain lengths, suggesting that if you have shorter chain lengths and the cholesterol no longer can intercalate with the membrane, you get a higher membrane fluidity and a bigger rate of metastasis. Interestingly, we find these associations for pancreatic cancer and also for colorectal cancer, but not for lung cancer, neither small cell nor large cell lung cancer, and also not for breast cancer. So it doesn't seem to be an effect of adenocarcinoma, but there seems to be a different mechanism of action, pointing to the fact that simply ductal cells or something do not play the role, but we are currently trying to understand that. And we have preliminary data that the enzymes probably involved here are ceramidases, so CERS 1 and 2. So they seem to be counterbalanced, that chain lengths in this situation, but that is preliminary.
Another related question is, you look at for lipid metabolism, have a look at the adipose, adipocyte loss, and this is part of the testing as well, the loss of the adipose loss.
That's an interesting question. We haven't done that. But we should, yeah, we definitely should.
Thank you.
Thank you very much. So I think it's again time